Picture this. You've been in pain for months. Maybe it's debilitating period cramps or a headache that won't quit or something in your chest that just feels wrong. You finally go to the doctor, and they tell you you're probably just stressed, or it might be anxiety. Or, and this is a real one, have you tried losing weight? You leave with no diagnosis, no answers, and a quiet, creeping feeling that maybe you imagined it. You didn't. And today, I'm going to tell you exactly why this keeps happening, because there is a name for it, there is science behind it, and it is not your fault. What you just experienced is called medical pain bias, and it sits inside a broader pattern researchers call medical gaslighting. Now, gaslighting is a term you've probably heard. It comes from a 1944 film where a husband manipulates his wife into doubting her own perception of reality. In medicine, it describes what happens when a patient, usually a woman, is made to feel that her symptoms are exaggerated, psychological, or simply not real. But here's where it gets interesting from a psychology perspective. In most cases, your doctor isn't doing this on purpose. They're not being deliberately cruel. What's happening is something far more insidious: implicit bias. Implicit bias means the unconscious assumptions our brains make about people, assumptions shaped by the culture we grew up in, the media we consumed, the stereotypes we absorbed without even realizing it. And one of the most deeply embedded stereotypes in medicine is this: women are more emotional, more dramatic, and less reliable reporters of their own pain. Your doctor may genuinely believe they're being objective. That's what makes implicit bias so dangerous. It doesn't feel like a bias. It feels like clinical judgment. The doctor isn't thinking, I'm going to dismiss this woman. They're thinking, this presentation is consistent with anxiety. And they reach that conclusion faster, with less evidence, than they would if you were a man sitting in the same chair describing the same symptoms. That gap between intention and impact is where the damage lives. This isn't a new problem. It's centuries old. For most of medical history, women's pain was literally classified as a psychological disorder. The word hysteria, which comes from the Greek word for uterus, was used to diagnose women with everything from anxiety to epilepsy to just being inconvenient to men. We got rid of the diagnosis. We didn't get rid of the bias. A landmark study published in the Journal of Pain found that women waited 16 minutes longer than men in emergency rooms before receiving pain medication, even when they reported the same level of pain. A different study found that doctors were significantly more likely to prescribe pain medication to men and sedatives or anti-anxiety medication to women for the exact same symptoms. Read that again. Same symptoms, different treatment. The psychologist Diane Hoffman calls this the Yentl syndrome, a reference to the Barbra Streisand film, where a woman has to pretend to be a man to get what she deserves. In medicine, it means women are taken seriously only when their symptoms mirror those of male patients in the research literature. And the research literature is a whole other problem. For decades, women were excluded from clinical trials, partly because of concerns about pregnancy and hormonal variation. The result? Most of what doctors learn in medical school about how symptoms present is based on data from male bodies. So your doctor isn't just carrying a bias, they're working from an incomplete map. Now layer on top of this the concept of credibility discounting, a term from feminist philosophy that describes how certain people are systemically trusted less when they give testimony. Women, particularly women of color, are credibility discounted in medical settings constantly. Black women face this at terrifying rates. Research shows their pain is undertreated more than any other demographic group, partly due to a persistent and completely false belief that Black people have higher pain tolerance. This is where individual bias meets systemic racism. It's not just about gender. It's about whose body is considered the default and whose experience is considered real. Here's the part that keeps me up at night. The dismissal doesn't end when you leave the clinic. It follows you home, and it rewires how you relate to your own body. When you are told again and again that what you feel isn't real, or isn't serious, or is just something, your brain starts to absorb that. You build what psychologists call a schema, a mental framework for interpreting your own experience. And the schema sounds like this: I'm probably overreacting. Over time, this starts to resemble something close to learned helplessness, a concept originally studied by Martin Seligman. When people are repeatedly exposed to a situation they can't control or change, they eventually stop trying to change it, even when they could. Women who have been serially dismissed in medical settings stop going. They stop reporting new symptoms. They push through things they shouldn't push through, not because they're tough, because the system taught them that speaking up doesn't work. And then something else happens, something quieter and more corrosive. You start performing. Not performing illness, performing credibility. You learn which words to use and which to avoid. You know not to cry, because tears get coded as emotional instability instead of a response to physical suffering. You flatten your voice. You bring notes, timelines, printouts, building a legal case for the right to be heard. You rehearse in the car. You edit yourself mid-sentence. You become your own translator, converting the raw language of pain into something clinical enough for the system to accept. This is an extraordinary cognitive burden, and it falls entirely on the patient, on you, to do the work the system should have been doing all along: listening. The sociologist Tressie McMillan Cottom, writing about her own near-fatal experience with medical dismissal as a Black woman, described this as a competence that shouldn't be necessary: the skill of making your suffering legible to people who are structurally inclined not to see it. There's one more thing worth naming. When your physical symptoms keep getting reframed as psychological, you start accumulating a psychiatric history you may not actually have. Each time a doctor writes anxiety or low mood in your chart, instead of investigating further, it goes in the notes. And the next doctor reads those notes, and the next one. What builds over time is a medical narrative that confirms itself, not because you were ever accurately assessed, but because each new clinician inherits the assumptions of the last one. You're not starting fresh. You're starting buried. Knowing this doesn't fix it. I want to be honest about that. But understanding the psychology behind why this happens can do a few things. First, it can help you stop internalizing it. When a doctor dismisses your pain, it is incredibly easy to walk away believing them, to think you're being dramatic, to minimize your own experience. Knowing that this is a documented, measurable pattern means you can name it instead of absorbing it. Second, it can help you advocate for yourself. Researchers who study patient-doctor interactions have found that women who come in with written notes, specific language, and a clear timeline of symptoms are taken more seriously. Not because it's fair, it's not, but because it works. Ask for a referral. Ask what specific tests would rule out a physical cause. Ask them to document in your notes that you reported this pain. Third, and this is important, it's okay to change your doctor. You are allowed to find someone who listens. The system needs to change. Medical education needs to change. But while we wait for that, you deserve to be believed. The psychology of medical gaslighting is one piece of a much bigger picture of how women's experiences are systematically doubted. And next week, we're going to go even deeper on that. Because in the next video, I'm asking, why were you taught that you're too sensitive? And what does psychology say about what that actually did to you? If this video resonated with you, Share it with a woman who's ever been told her pain was just stress. Subscribe so you don't miss the next one.